Hi, everyone. Welcome to this episode of RevDive. I'm here today with Claire Ernst, and we're going to be doing Spill with the Hill with Claire. Claire, thank you so much for joining us today.
Thanks for having me. It's good to be back.
Yes, we're so glad to have you. Now, you have, a long history of, advocacy and direction when it comes to healthcare legislation. Can you just give our viewers a little snippet of what your, background has been?
Yeah, sure. So my background really began a long time ago because I was raised by psychologists who actually own their own practice. So it's funny that now I guess I represent physician practices because I grew up kind of, always in the periphery of that. So at MGMA, I am the director of government affairs. And so I always give my literally caveat of these are all my opinions, not MGMA's opinions. Although I will talk about some of our advocacy, I'm sure, as it comes up. But yeah, I do a lot of regulatory work, a lot of legislative work, a lot of just fun stuff. I was just telling Kim before this that I thought, I was hoping it would be kind of a slower August recess, but it's not turning out to be that way. So we have a lot to talk about, I guess, because it's not slow.
I mean, just with a busy August, we did get an update on the proposed 2020 fee schedule.
Mm-hmm.
Can you talk about that? I mean, I've read it, but oh my gosh, just like, what are your thoughts?
Did you read it like a nice glass of red wine and just
Yes.
unwind? Yeah. No,
And
it's
popcorn.
great. Yeah, exactly. So yes, the 2022 proposed rule came out in July. And so me and our government affairs team spent, a couple of weeks going through almost, 2,000 or so pages of all the proposals. A couple of things that jump out to me that I think are of note. One, the conversion factor being 3.75% lower than what it gives. No, yeah, it's lower, but that also wasn't a surprise because last year, Congress had allocated $3 billion to the Medicare Physician Fee Schedule to mitigate the cuts that we were anticipating. And they delayed the complexity add-on code for 3 years, which added a few percent back in. So that's delayed for another 2 years. So that's why it looks like 3.75% lower for next year, not a larger sum. So we will have to go to Congress to ask for more money, which I'm sure they'll love. There is this option potentially of Medicare just waiving budget neutrality. I think that, our tactic, it's kind of a larger tactic of many societies. There was a letter that we signed on to that asked Congress to maintain that 3.75% for the next 2 years.
Mm-hmm.
So we will see when they get back if we can get that going. But I think along those lines as well, there are some other financial housekeeping issues, such as the statutory pay-go situation that they, just for those who don't know, when the American Rescue Plan was passed, it was a large ticket item. And so, basically, Congress can waive essentially the scorecard, just keeping track of how expensive everything is. And the problem, though, is that you can't actually waive it for anything that goes through reconciliation. And this went through reconciliation. So we had to wait for we had to wait for Congress to waive it in any sort of next round of legislation. But because the American Rescue Plan was so partisan, they weren't, they didn't jump to waive anything. So we also need that to happen before the end of the year to prevent 4% for pay-go. And then we have 2% for the Medicare sequester that's been in effect for almost 10 years now, but it has been waived since last May, when the CARES Act put a moratorium on it. So,
Right.
yeah.
Lots of interesting developments with the fee schedule. What advice do you have for practice executives in terms of, getting prepared for these potential changes?
Yeah, so I mean, I'll put my plug in for MGMA because, like, we read this stuff, so you don't have to read all of it. But yeah, I mean, I think like a couple of things to pay attention to and just be on the lookout for. So anyone who does a lot of, like diagnostic imaging, who was concerned about the appropriate use criteria program, that's a program that was passed in PAMA in 2014. This program would essentially require you to use a certain software that would okay whether or not you could order tests. And then the ordering physician would have to attach a number essentially to the claim for the rendering one for payment to proceed. So that was something we had concerns about, because CMS is also just not ready to process any of those claims. And it also would require getting an upgrade to your EHR, require a lot of different, like workflow issues. And so that's delayed for at least 1 year. So that was a positive. Yeah. Yay. Snaps for CMS. Yay. Yeah. Another thing that I know Kim was excited about is we like to chit chat E&M. So evaluation and management services, couple of changes there. Some of them are about split or shared services. Some of them are about critical care services, and some are about teaching physician services. I think the most, the one that is the most, that's going to have the largest impact would be with the critical care services. And
I
so
agree.
being able to they essentially modified what it means to bill during a global period. And they also said, you can't bill the E&M visit and the critical care visit during the same day, which is going to affect certain practices more than others. But I mean, my gut reaction to that is that to penalize a physician for essentially not being able for a patient to change their status, if they had already, they were in the facility, you checked in on them, you billed E&M, and then all of a sudden you have to bill critical care. To me, that doesn't make a ton of sense, but I also don't think it's something that is relevant for every specialty all the time. So you just have to look out for if that's something that you typically do.
Yeah, very true. I used to direct a critical care group, so I know that community of physicians are going to be paying very close attention to what comes out of all of that.
Yeah, definitely.
Now, one other point that I wanted to just kind of pick your brain about is the telehealth, the future of telehealth, really. And, the fact that there's a proposal to remove the geographic location, all of that, those restrictions. What are your thoughts about whether or not that will actually happen?
So in the fee schedule, they are essentially codifying provisions in year-end legislation. So going back in our legislative time machine to last December, it was just a mad rush to get a lot of things done.
Right.
And we were very distracted with surprise billing, and there were a lot of things getting thrown into this, and the E&M cut, mitigating the conversion factor cuts. So it was my December was just I slightly repressed it, but part of the legislation that got in was actually about mental health visits, and following the public health emergency, you would be able to, for mental health services, you'd be able to use the home as an originating site, and you would be able to do it regardless of geographic location. But there was a 6-month in-person requirement. So basically you had to have seen the patient in person 6 months prior to doing the telehealth visit. Now, a lot of the, psych mental health community was upset by that, what they would probably say arbitrary in-person visit.
Right.
I know, for instance, like my dad, who's a psychologist, was like not thrilled about it. And I actually was looking like, just like going back, trying to find like, why 6 months, like is this pulling from somewhere else on Medicare? And no one really knew. But they're doing it, I mean, I assume because they're trying to, put any sort of guardrails, like safeguards in for like potential fraud, potential, like overspending. That being said, there is legislation that's been introduced to get rid of that 6 month.
Oh, that's awesome.
So we'll see. I talked to the sponsors a few months ago, and they seemed pretty optimistic. I think the only concern is like they just passed that legislation, and so there might be some critics that are like, "Well, why, why are we redoing what we just did?" That being said, the physician fee schedule is essentially codifying what was in the law, so they're proposing it, but they kind of have to because it was, like essentially, in layman's terms, like a directive from Congress. So yeah, I mean, I think that it's great. I think that mental health, like personally, like I think that mental health needs to be invested in more. I think telehealth and virtual services lend themselves very well to this sort of environment. Like I've done appointments via the phone before the pandemic, and it's been like great to be in my car. That being said, I think there's some interesting issues with like how we, like defining the home and like, in a situation, right, where like, I mean, this is Medicare beneficiaries, but like, for instance, I feel like I do half of my business like on the way to work or like in the car. And we were kind of joking around with this, like I have my telehealth work group at MGMA, and we were kind of joking around about like, I'm like, well, my car, even though it might feel like a home, it's not my home. So, I think that'll be interesting, as opposed to just like completely, like waiving originating sites in general, or like if you're doing work at like an assisted living facility, whether they're not like an actual permanent patient, but they're there for a period of time. So I think that is very niche to certain, specialties and subspecialties, but I think it'll bring up some interesting questions. So I think that it's good that they're doing this. I think that, it was interesting that they took a step, like they took even a step further and started to go expand, or proposing to expand audio only visits for these services, like for, diagnosing and treating mental health services.
Yep.
I would like to see it expanded to more than just mental health services. Like I would like to see it expanded to the audio, like E&M visits that we saw covered, like 99441 through 43.
Yep.
I feel like those numbers are like imprinted in my brain forever after 2020. But yeah, I mean, I think that it would be great to get those reimbursed. I mean, the problem too is that, in order to make them sustainable, we also have to make sure there's some, we have to, like, the question of payment parity is going to come up, which is essentially a CMS issue. And so just because you get these things extended and expanded doesn't necessarily mean that they're sustainable, right, to continue to do. That also being said, I feel pretty strongly, and it's probably because I represent physician practices, that we have to make efforts to keep patients within the practice and within their like physician-patient relationship. And so whenever I talk to Congress about this, because everyone's like pushing for telehealth, it's like a very multi-stakeholder, like situation. You got like all the vendors and, and the providers and even the insurers. But I mean, what I don't want to happen is like to see like telehealth for like Teladoc get, Medicare credential enrolled, and then to have patients who have a ton of comorbid issues, like and plenty of medication, and they're like calling up, whatever, Teladoc or whatever. single them out, but like a vendor.
Yep.
And, it's, and then that they get essentially disrupts care and it's taken out of the practice. And then, they go back to their doctor and their doctor doesn't know that they're on, X, Y, and Z for like some sort of, condition that they were prescribed something over the phone. And so we have to find ways to deal with that. And I'm not sure necessarily what that looks like yet. Like it's percolating. I'm trying to find, whether it's an established patient situation, like I'm not sure, but it is something that I keep underscoring as we expand.
I think our provider community can really really drive that patient relationship in a number of ways, not just an in-office visit, like staying in touch with them virtually through a patient portal, keeping health campaigns going through their patient website, reminding patients to come in to get flu shots or, whatever, kind of preventative services that they might need. But the other thing I think that physicians can do to kind of drive that process is documentation, showing the complexity of that patient's care, especially when it comes to payment parity. Because I'm sure that, I know that the, payers are looking at telehealth services to determine whether or not they are as complex as in an office visit and whether or not the same medical decision making is taking place in a telehealth visit versus in an office visit. And I would say for the most part, it's the same. It should be the same because they're both being reimbursed the same.
Right.
So it's really just about making sure that our providers are doing that documentation and showing that level of complexity, but then having that, kind of post telehealth visit communication with the patient, whether it's the medical assistant checking on meds or referrals and, just kind of keeping that communication going.
Yeah, I think that's a really good point. And, all indications throughout this pandemic have been to me, like, as I talk to physician practices, so that, it's not any easier or like cheaper essentially to deliver these services. I mean, you have the IT infrastructure, you have to troubleshoot, you have to this is clearly not the same thing, but I remember like moving, like getting a house and moving last year, I couldn't even get upgraded internet for like 3 weeks because everybody was doing it at the same time because everyone needed to like distant learn and distant work. And I'm just like, it's not necessarily more convenient. I mean, it's also interesting to like for scheduling reasons, like there's some issues with like workflow and scheduling via telehealth. You have to figure out like post-pandemic, if even before, because people have gone back to seeing physicians in person, but you have to figure out if there's going to be like one person who's going to kind of do telehealth, they're going to rotate in, whether or not they're just all going to offer it, for family practice, for instance, people really like their own family practice doctor, like I feel like, so you can't just have like one person necessarily at the practice be doing all telehealth for all patients because maybe that patient wants to see their doctor they've been seeing for 10 years. So, I think it's interesting. I think we'll see, what ends up happening. Ultimately, Congress sort of holds the cards for this. What I think is going to happen is that there's a lot of momentum like pushing this forward to expand these flexibilities in perpetuity. I think there's also a lot of concern with fraud and cost of the program and quality outcomes. Just listening to the last few hearings on this, like a few months ago in March, that was a huge concern, like an Energy and Commerce Committee hearing. I think that they will end up making a lot of these flexibilities, like the geographic originating site, like perhaps a qualifying practitioner, since PTs and I think OTs and SLPs were not included. I think they will make that permanent for 1 or 2 years because it's in line with what MedPAC said. MedPAC didn't give an official recommendation, but they did put in their last report a lot of information about what they thought would make the most sense. And they said for a period of time while they collect information. And I think that's what's probably going to happen towards the end of the year or whenever we think that apparently we're going to get a 60-day heads up if the administration's not going to renew the public health emergency. So it might be one of those situations where like we get the 60-day heads up and Congress finally moves, and hopefully it's not during like, I don't know, the holidays.
I mean, we're
But
getting close to
yeah.
that time.
But that's kind of what happens usually, right? Like I think
Yeah.
it'll kind of be like almost like an appropriate, like renewing programs, like I think that'll be kind of the situation until they have enough information. So
Yeah.
I think information matters. I think we should expand it, but I think a lot of it should be up to the physician's discretion on whether it makes sense to see this patient or not via virtual care.
Right.
And it's
Right.
their preference too.
Yeah.
But I think that, to make the point that it's that it's something that should be sustainable and should stay, it's good either way to have that information.
So true. Now, as we're wrapping up, we can't leave without just kind of seeing what's happening in Congress.
Okay.
What's happening in Congress?
What's happening? Well,
anything interesting that we need to be aware of?
So, I mean, right now the attention has been primarily focused on infrastructure. I'm sure like everyone has seen the news. So it's like infrastructure and budgeting, budget resolutions. And so I think, it's interesting. With the infrastructure package, it was mostly like physical infrastructure, as opposed to like we had we had asked for other things to be included that were more healthcare, like personnel, sort of, like the cuts. But they did, like one of the pay fors is to essentially expand the 2% sequester. So we were like, there was not a lot of it was not a great thing to learn as a pay for. And I think what's going to be interesting with like the budget resolution is a couple of items in there are like including more like expanding Medicare with like vision, dental. So I think we'll see what happens. I mean, hopefully they enjoy their vacation in August and they're going to come back ready to go. I don't know if I'd want to be a Senate staffer like the other week, because they definitely had some really long, between the votorama and everything. They had a very long weekend week. So but I think, if I come back in the fall, I think we'll have a lot to talk about, because I think they're going to hit the ground running. I know we will with a lot of our priorities.
Well, Claire, thanks for joining today. This has been so much fun. We always love having you with us.
Thanks.
Look forward to seeing what's coming down the road in the fall. We'll definitely bring you back. Thank you so much. And everyone, thanks for joining us today. We'll see you on the next episode of RevDive.
Thank you.